Well, greetings everyone, and welcome to the EKG case for the week of December 24th, 2012. I hope everyone's having a great holiday season thus far in your celebration of Christmas or Hanukkah, Kwanzaa, and of course, Festivus for the rest of us. So I've got a very nice case this week. It's a very timely case, and you'll see why. This was sent by a good friend in Pennsylvania by the name of Chuck Warlow. He is a clinical professor of emergency medicine and helps oversee the medical student education at Lehigh Valley Hospital in central Pennsylvania. And they were taking care of a 47-year-old man that got sent into the emergency department because of unresponsiveness. Now, this patient has a history of a prior motor vehicle accident and ended up paraplegic at around, well, I guess, the C5 level or so. But anyway, he was brought in because he was unresponsive. He's got some abnormal vital signs. He's hypotensive and somewhat bradycardic, which may be kind of related to his spinal cord injury, but he is a bit hypothermic, and although he woke up just a little bit, he didn't really have any complaints of pain. And so you figure in this type of patient with those vital signs, the first thing hopefully you're thinking of is some type of sepsis. So we're going to send off the urine and get a quick chest x-ray, since those are the two most likely sources of sepsis. We'll start warming up the patient. And of course, you're going to start with an initial EKG, right? That's what the E in ABCDE stands for: airway, breath sound, circulation, dextrose, and EKG. Or sometimes I like to say that the C stands for cardiogram: airway, breath sounds, cardiogram. But anyway, that's what they do. They got a 12 lead pretty quickly, and there were some concerns on this thing. The patient is bradycardic in the 50s, but they also were concerned about some ST segment elevation in the inferior leads, maybe a tad bit in lead 3. There's also some clear-cut ST elevation in the anterolateral leads, and this doesn't really correspond with a specific anatomic location. So one of the things you're going to be thinking about is pericarditis. Does he have pericarditis? Is he hypotensive because of tamponade? You know, who knows what's going on here? You look at other findings for pericarditis, there's really no PR depression that we would typically think about. And of course, everybody hopefully is looking for a spodic sign, downsloping TP segments, and well, unfortunately, those aren't there. And so there's nothing definitely pointing towards pericarditis. The first thought, of course, especially in a 47-year-old guy, is could this be a STEMI? Well, he does have ST elevation in the inferior and the anterolateral leads. Well, I suppose that could be a left circumflex lesion. So what did they end up doing? Well, you look at the computer interpretation and it's saying acute pericarditis. We've kind of addressed that already. So I think we're not guaranteeing anything about pericarditis versus STEMI. It's not heading in one direction or another. So is this pericarditis? Is this STEMI? Could this just be hypothermia or sepsis? Those are going to be in there. And of course, you're going to think about early repolarization and aneurysm and all the other usual things. But these were at the top of the differential for Chuck and his team. They got a quick echo, and there was no evidence of pericardial effusion. So that pushed them away a bit from pericarditis, and it certainly ruled out large effusion or tamponade as a cause of this patient's hypotension. They got cardiology on board very appropriately. Cardiology said, you know what, let's remove any doubt. Let's take this patient up to the cath lab. And you can't argue with that. It's great to have aggressive cardiologists. The patient ended up having clean coronaries. So we can take this off the table. And what then? Well, by this point, they had warmed up the patient. And with warming, what do you know? The ST elevation has resolved. And it turned out that this patient's ST segment elevation presumably was purely from hypothermia. The patient did, in fact, have sepsis and was treated for pneumonia and bacteremia probably from that pneumonia. And I think he ended up doing well. EKG elevations resolved with warming. But it's an interesting case that Chuck had sent. And I think it's a very nice reminder, or maybe it's new learning for some people, for a lot of people, that hypothermia is in the differential for ST segment elevation. Now, normally when we teach EKGs, we don't spend a lot of time talking about hypothermia in the differential for ST elevation because you can usually evaluate hypothermia with something called a thermometer. And in this case, they did know the patient was hypothermic, but there were some other confounding factors going on, making them wonder, well, is this elevation purely just hypothermia, or is there something else going on also? So this was a nice reminder that hypothermia can be the pure cause of ST elevation. The literature also suggests that hypothermia can produce ST depression as well. There's literature about that. And just as a quick review of the different things hypothermia can cause, these are not listed in order of occurrence, and certainly ST segment elevation or depression goes a little bit lower on that differential. But tremor artifact is very common. What does that mean? Well, the baseline oftentimes looks like there's just a little bit of a tremor because the patients oftentimes shiver, and that can often, frequently be misdiagnosed as atrial fibrillation. So you need to look very carefully and see if there's any P waves that may be popping up amidst that tremor. Anyway, Osborne waves, the J waves are Osborne waves. Let's go back to the initial EKG again for just a second and take a look. What are J waves or Osborne waves? Those are those that's the little blip that comes right after the QRS complex right there. All right, so the QRS complex goes up, down, and then there's a blip, and that's referred to as the J wave or the Osborne wave, and that can produce ST segment elevation in all of the leads where there is an Osborne wave or a J wave. And that'll give you the false impression that there is ST segment elevation associated with a STEMI, or it may make you think about pericarditis, but ST elevation occurs oftentimes in these settings of hypothermia because of those J waves or Osborne waves. Well, bradycardic rhythms are very common. It can be sinus or it can be junctional. You get prolongation of all of the intervals. This patient had a prolonged PR and a slightly prolonged QRS. You oftentimes can have a prolonged QT as well. So hypothermia prolongs all of your intervals. You can also get atrial fibrillation, and because of the bradycardia that's associated with hypothermia, it tends to be a slow, irregular atrial fibrillation. And I highlight the word irregular because if you ever see a slow, regular atrial fibrillation, you're going to think of DIG toxicity. But if you see a slow, irregular AFib, think about hypothermia. Of course, drugs can do it as well, but think about hypothermia. And then at late stages, you can get ventricular fibrillation, and of course, you can get asystole as well. So anyway, it's just a nice differential for the different EKG findings associated with hypothermia, and also this case was a nice reminder that you can get ST elevation because of those J waves in patients that have hypothermia. If you want to reference, this is I think it's a pretty nice reference actually from 10 years ago that a couple of EKG buddies, Bill Brady and Andy Perrin, and I wrote up for American Journal of Emergency Medicine. There's a handful of cases in this review article, including a hypothermic case. So my thanks to Dr. Chuck Warlow for sending a very timely case of hypothermia. Be on the lookout for hypothermia. Look for those J waves. And just remember that you can get ST elevation from hypothermia in the leads that have those Osborne waves. To finish things out, just as a complete aside, I want to thank one of our residents, Dr. Katie Bogger, for these cookies, very seasonal cookies as well. Katie's a great resident, okay? It's not even for this reason. But clinically, she's a great resident. And then what really puts Katie over the top, she's a great baker, and she baked some cookies for me. These are holiday cookies. And to put icing on the cake or icing on the cookies, she baked EKG holiday cookies. So she decorated these as EKG strips. That's how amazing Katie is. So if you look up here, what's the diagnosis? Well, there's a short PR, delta wave, wide QRS. This is the WPW cookie, all right? This is irregularly regular. This is your atrial fibrillation cookie. And this is a deep, wide S wave with the little R wave in V1. This is your left bundle. That's your right bundle branch block cookie. This is your VTAC. Got to shock that cookie. This is your atrial flutter, which didn't quite make it home intact. But the atrial flutter with a broken heart there, I guess. And this is torsade de pointe. So how about that? She made cookies that made me, I kind of wanted to save these cookies, but honestly, they didn't last in my family for very long. So my thanks to Katie Bogger for these cookies. And they were great. And if anybody out there is looking for a wonderful emergency physician who is also a great cookie baker and is also a budding EKG nerd, send me an email and I will put you in touch with Katie. She's about to graduate. So thanks, Katie. Thanks, Chuck. And my best wishes to all of you for a great holiday season, safe, happy, and also have a really, really great New Year. I look forward to talking to you again in another week or so, and we'll be just about ready to celebrate the New Year at that point. So until then, be safe, and I will talk to you in a week. Bye for now.